it is time for our keynote conversation. What does equity have to do with aging in community? And I'm going to share the slides correctly now. It's my great honor to introduce our keynote speakers. Denny Chan serves as the Managing Director of Justice and Aging's Equity Advocacy Team. In this role, he is responsible for developing and leading Justice and Aging's strategic initiative on advancing equity, with a primary focus on race equity for older adults of color. And he also coordinates the organization's equity team. Dr. Terry Hill is a local geriatrician who has worked in private practice and in multiple executive roles. Most recently, he served as COVID-19 medical director for the Alameda Contra Costa Medical Association and as a volunteer with the Alameda County Department of Public Health. He continues to be involved in multiple statewide professional and policy organizations and is a great mentor for our coalition. Thank you, Terry. And to moderate this keynote conversation, I'm very pleased to introduce Kweli Kitwana, who has served as Senior Services Coalition's Associate Director of Policy Advocacy since 2017, and brings a combined 35 years of experience in local, state, and national grassroots advocacy and progressive policy. So Kweli, I am going to hand it to you, and I will back you up advancing any slides that you guys want to look at.
Great. Welcome, everyone. It's good to see everybody, and I'm excited about this keynote panel. It's a pleasure to have planned and worked to pull this panel together with both Denny and Terry. I wanted to just really use this time to ground us all in this important conference that we're having around inequities. And we've asked our keynote speakers to join us in a conversation addressing a couple of questions, or actually a question. Primarily, that question is, what does equity have to do with aging in communities? And more specifically, with who has access to alternatives to institutionalization? Their conversation should help us, and we're hoping help all of us understand how important it is to ensure equal access to alternatives to institutionalization. Terry and Danny will share findings that they've been closely connected to and have incredible amount of information to share with us that show that older people of color, in particular in our county, particularly Black people, have fewer alternatives and worse outcomes when it comes to aging in Alameda County, with the challenges that come along with aging. Obviously, inequity impacts many communities of color, and we will be addressing that. But one of the things we wanted to ground everyone is understanding that disparity does matter disproportionately in terms of how things impact aging older adults in our communities. And so it's not enough to just say, people of color, or point out very specifically what's going on and happening, but for us all to be grounded in how this disproportion is a critical part of inequity. And they would identify how these inequities play out and share with you some very specific information. So with that, I will kick it off by having Denny kick us off, and then we'll move to Terry. Thank you.
Great. Well, good morning, everyone. Good morning, Kweli. And I'm so happy to be here with all of you. Thank you for inviting me to be with you this morning. You can pull up my slides. So I know this is a really big question, the question of what does equity have to do with whether you can age in the community? And as I was preparing for this conversation, and we had some conversations behind the scenes earlier this week, I thought, well, how do we even start answering that question? It's so incredibly complicated how we got here today. And I thought maybe it would be helpful, I'll explain kind of a little bit later what Justice in Aging does and who we are and what we do, but I thought it'd be helpful to zoom out a little bit. So, Terry's going to dive in really deep into a local perspective. And what I'm going to try and do in my short time with you all today and in this dialogue is really lift up what we're seeing across the country and how we got here today across the country. So if we can go to the next slide. Justice in Aging, if you haven't heard of us before, we are a national legal advocacy organization. We use the power of law to fight senior poverty. And I use he, him, his pronouns, and I'm based out of Sacramento, California. We have a number of staff in California as well as a number of staff in DC. And in light of the COVID-19 pandemic, a number of staff who are working remotely. And in 2021, we launched a new initiative to advance equity for older adults with a specific focus on older adults of color. So next slide. We provide a lot of resources to people who work with older adults, so you can feel free to go to our website at justiceinaging.org and sign up for our alerts and materials if you haven't already. And I promise you, you can always unsubscribe if you find that we are sending you too much mail. Next slide, please. So we have a commitment internally and externally to advance equity that involves advancing equity in our programs and our programmatic advocacy in economic security, healthcare, housing, and elder justice. And it also means committing to equity at home through the recruitment and retention of a diverse staff and board among many different types of diversity. All right, next slide. So, in preparing for this conversation, I thought the theme that we had picked up on in our behind the scenes conversations was that there are a lot of myths around older adults, aging, and equity. And what I'm hoping to do is start to unpack why some of those myths are myths and actually, why they're not helpful if we think about older adults and equity. And one of the first things that we come up with, is people sort of scratching their heads and saying, well, older adults are not impacted by equity. Or they'll say, well, the older adults that I work with are primarily white, and so these issues don't impact them. And that's false on two different levels. Older adults are impacted by systemic discrimination in two very specific ways. The first is ageism. And we don't need to look further than COVID-19 to see all the different ways in which ageism played out in our society. But if we take a more granular approach, sometimes people will say, well, Denny, those are just popularly held opinions, right? Like that's a cultural thing. We don't have ageist policies. We don't have ageist laws. And if we think about what happened during COVID-19, let's keep on the same slide. Thank you. If we think about what happened during COVID-19 during the crisis standards of care, when we started rationing care because we didn't have enough resources, our progressive state, California, in draft guidance through their crisis standards of care document, actually allowed for age-based tiebreakers. In other words, if you ran the formula and you had one ventilator left and two patients, you could use age to break that tie. That was draft guidance that our state was about to release until we and other advocates said, California, you can't do this. This is the wrong way to go. So it's an example of how commonly held beliefs actually impact policymaking from an ageism perspective. So that's one way in which older adults are impacted by systemic discrimination and why equity matters to them. Another is one that we've already started talking about in the earlier conversation, which is that racism and other forms of systemic discrimination impact older adults. And we often, I think, it's just our way of thinking about people. We break them down, right? We sort of lose the multiple dimensions of who people are. So in conversations that I have with racial justice advocates, they're not thinking about the older adults in their communities. And vice versa. In conversations I have with aging advocates, they're not thinking about those older adults as older adults of color. And the more that we sort of bifurcate, the less we're able to see very specific challenges and unique circumstances that people experience as a result of lifetime of discrimination. Next slide. So we're continuing on myth 1. And here are some other examples of how this plays out. Again, the myth here is that older adults are not impacted by equity. One, we saw during COVID-19, particularly as we're having this conversation about long-term care and options, is that the California Healthcare Foundation released a study during COVID that said the higher proportion of Black residents, the higher risk of outbreak in that skilled nursing facility. And so that's showing you that there is something happening here around community spread, around who is more likely to get COVID, and I'll get to that in a little bit later. And then I will also say, this big question, Kweli, that you kicked us off with, what does equity have to do with whether you can age in the community, is the second piece around rates of institutionalization among racial groups. And I know that Terry's going to get to this in more of a local perspective later, but there is research as early as 2011 illustrating that there are higher rates of admission. I'm trying to get the language right here, that the rates of admission for communities of color into nursing facilities is higher than their growth in the general population. And so what sometimes people will say is, well, they're being admitted to nursing facilities because they're growing at higher rates in the population, and that white people aren't growing as high of a rate. That's actually not true. If you control for the rate of growth in the population, you will see that they're still disproportionately being admitted to nursing facilities. And then that, I think, turns on the question of, well, why is that? What are the other options available to those people? Second slide.
Danny,
Go ahead.
Add another myth around why people may enter into nursing homes, and one of which is that there's a myth that it's like a cultural thing, that, some cultures take better care of their aging community than others, or some cultures, it's not a part of their culture to institutionalize their aging family members. So again, that's one of those ways where we have to unpack that and not let that just hang out there. So continue.
Absolutely.
Thank you.
I completely agree. So the second myth I want to tackle is, and one of Wendy's slides teed this up very well, is people often say, well, if you address poverty, then aren't you also addressing race? Because these two are interchangeably linked. And it is true that race and poverty have a very complicated relationship, but it is not true that you can just sub one in for the other. And so the example here that I'm trying to pull up is COVID-19 hospitalizations for Medicare beneficiaries. This is what that chart shows you, that you can see here. And what you can see here, the blue bars are Medicare beneficiaries who are Medicare only. The yellow bars are people who are dually eligible. And I know we're not going to do acronyms. So these are people with Medicare and Medicaid, or in California, we call that Medi-Cal. And so what I'm trying to say here is that the rates of hospitalization are lower for all racial groups when you look at Medicare only. And so they're higher for duals, for Medicare and Medicaid beneficiaries. And that's the impact of class. That's sort of my argument, is the impact of class and poverty. But if you look then just at the yellow bars, you will see that the proportions of hospitalizations for American Indian Alaska Native, for Black and African American, and for Hispanic older adults on Medicare are higher than whites, even when you control for Medicaid. And so to me, that suggests there's something else going on. You can't just swap class and race. Next slide. And then finally, the third myth, before I turn things over to Terry, who will take things down to a local level and continue with the conversation, is myth number 3. Well, people will say, you know, they're doing the head scratching. Advancing equity is not part of my job. I'm simply responsible for delivering meals. I'm simply responsible for case counseling. I'm simply responsible for doing this specific function at a health plan. And I think it's really time that we all think about advancing equity as part of all of our jobs. That is one of the biggest barriers to moving forward in having aging and equity really combined together. And here I list, if you think that it's not part of your job, I'm sort of telling you the trend is it's an increasingly part of all of our jobs. The Older Americans Act, specifically in regulation, requires targeting older Americans and older adults who have the greatest social and economic need. And that's further defined in statute to include linguistic and cultural isolation. There's a growing number of executive orders, both at the state level, Newsom's executive order N1622 to advance racial equity, as well as President Biden's now 2 executive orders, 13985 and 14091, all of which are about advancing and promoting racial equity. And then finally, you know, to all of you who work in the healthcare infrastructure and the healthcare system, CalAIM is all about ending disparities, right? CalAIM is all about improving the Medicaid program to end disparities. So for all of you who are still thinking, well, this is not part of my job, I don't see the connecting the dots here. The trend here is that this focus on equity is not going away. This focus on equity for older adults should be part of all of our jobs. And the earlier that we start to operationalize that in how we approach services, then the earlier we can start to draw more commonalities and start to actually advance equity for older adults in policymaking. So I know that was super high level, but next slide, I think, is just my contact information. But I want to turn it over to Terry too, because I know he's going to take things to a local level.
Yeah, we'll take questions after Terry. Thank you, Terry. You're on mute. Also feel free to put your questions in the chat. Thanks, Terry.
So, I mean, Denny introduced an entire universe of issues. I'm like, okay, you know, Kweli and I talked about how can we focus some of this? So next slide. I thought, all right, I'm gonna tackle just 2 messages. I've got 5 slides that kind of illustrate this with local data. And, you know, the first is that one's housing depends more on your personal and family resources than on function and preference. And this speaks to the myth that, well, if you're really impaired, you're in a skilled nursing facility. If you're not as impaired, you know, not so impaired, you're at home. And if you're in the middle, you're in assisted living. Well, it turns out it doesn't play out that way. And then I just, you know, personally, I can't talk about older adult services without talking about the direct care workforce. So that's, you can skip the next couple of minutes because I've told you all I'm going to tell you, but I'll illustrate it with some data. So next slide. So these are old data, you know, from a few years back, but they really haven't changed. And starting from the top left, each bar here is a California county, and it shows the percentage of Black African-American residents in California skilled nursing facilities, right? So Alameda County is in red. Alameda County has the highest percentage of Black African Americans in its skilled nursing facilities. The next line is Hispanic Latino in red. You know, we have very few in Alameda County, comparatively speaking. The bottom line is, you know, we're in the middle in terms of poverty in Alameda County. We are not a, you know, terribly poor county, and which makes it all the more a shame that we do as badly as we do around some things. So I find it really interesting on the right-hand side, though, to look at where are white, Black, and Hispanic Latino residents in nursing homes in terms of whether they're for-profit or not-for-profit. The first column is, you know, shows the white population, which is mostly in for-profits, but a huge chunk, the blue, in not-for-profit. But look at the difference with Black residents in nursing facilities. Very, very few in nonprofits, which tend to be a little better quality. And, you know, Hispanic, Latino, hard to find in the nonprofits, and mostly in the for-profits. Next slide. Then just, you know, the other myth is that facilities mean like nursing facilities, but there are these board and care homes, assisted living facilities. They're all licensed as residential care facilities for the elderly. And, you know, this is just a ground level setting slide here. There are 166 small board and cares. They have only about 10% of us, though, in terms of residents, and whereas most residents are in the large ones. And the critical piece here is that whereas nursing, your care can be covered by Medi-Cal in a nursing home, almost all of these beds in RCFEs, residential care facilities for the elderly, are private pay. Hello. That has implications. Next slide. And this, a messy slide, I apologize for that. But the message here is that if you look on the left-hand side, the adult ADHCs, adult day services centers and home health agencies, these are clients who are at home. And this is the level of impairment of people who are at home. And there's really not any difference between those bars that show impairments in bathing, dressing, toileting, et cetera, in home health agencies versus nursing homes. It's like the same level of impairment. And even for in the residential care, about half of the people in residential care need help bathing, dressing, and walking. So, you know, where you are depends upon basically, do you have resources to be cared for at home, or do you have enough resources to pay privately for residential care? Next slide. And then finally, a couple of slides on the data that I pulled by looking at every death certificate in Alameda County for the first year of the pandemic. The three different columns here: skilled nursing facility, residential care, continuing care, retirement communities. The continuing care retirement communities, you have to pay a bunch of money up front and monthly to stay in those. So you have to be relatively wealthy to be in a CCRC. And again, what I told you a moment ago was that to be in a bed in a RCFE, you need to be able to pay privately for the most part. Very few Medi-Cal beds. So if you look at the bottom rows, you'll see some incredible progressions about like how many are white versus non-white. In the skilled nursing facility, only 37% white. In the CCRC, 73%, with RCFEs in the middle. How many people have bachelor's degree or higher? 20% in SNF, 45% CCRC, RCFE in the middle. Born in the US, 65% in nursing facilities, 75% RCFE, 82% CCRC. And then, this died in the hospital. Where do people want to die? They want to die at home, wherever home is, right? And that tended to happen in CCRCs, not so much in SNFs. So there's this pattern of race and socioeconomic status that is so glaringly clear from the first year of the pandemic. Next slide. The other thing that you should know is that about 42% of all the infections from COVID that were related to long-term care facilities were in staff. And in just the data reflect who's taking care of us in these facilities. So on the left, you have the residential care. 92% of the people who got infected while working in RCFEs were unlicensed. 79% in CCRCs, which are a combination of SNF and residential care, and then 65% in nursing facilities. And there were 12 deaths. Did people sign up for this, to risk their lives taking care of us? There were 12 deaths among staff. 10 were unlicensed. 10 were Asian immigrants. All were people of color. I've never cried so much as I cried during the first year of the pandemic. This was, it was really hard. It's hard to even remember how hard it was. This was very painful. So let me stop there. And Kweli, you're supposed to rescue Denny and me.
Sure.
Oh, I threw some interesting websites in at the end, but that's for your perusal later.
Yeah. So, wow, I want to thank you all for kicking us off in such a powerful and heartfelt way. I mean, usually as we go through this work day to day, we do get like in a lot of like policy wonky and programmatic kind of language. And I just want to thank you all for grounding us in this in a very, I mean, I want to use the word brave, but just like, a very strong call to action kind of way, just enough to get us angry enough, all of us angry enough and moved enough to take this very serious. We have quite a few questions. I do want to let everyone know that I do have a dual responsibility to make sure that we end this panel on time, but also get you excited about the fact that most of which people who are raising questions around will be answered throughout the day, but most importantly, we will be giving written responses in our follow-up conference materials. But let me go back to a question that I want to throw out here to you, Danny, and that is, when I think about like equity and how it impacts individuals, the question that always comes to mind is, the goal is for everyone to be able to live successfully and certainly the best lives that they can in our communities as we all age. And I just want to ask you, whether you believe that that's that's possible, and then like what that's going to take for us to be able to do that. especially when it comes to, equity. How are we going to, successfully live in our communities as we age if we're dealing with issues related to inequity?
You started off with a big question and you're trying to end with a big question. So I will try to keep it short. I wouldn't do my job if I didn't think it was possible. But I think the hard part about the work that we do in striving for equity for older adults is that these systems, as I said before at the very beginning, are complicated. They are centuries-year old. I mean, these are like historical systems. We behind the scenes, when we talked earlier this week, we talked about redlining. We talked about like all these things that have really created the situation that we're in today. And so I think what it's going to take for us to actually achieve equity is lots and lots of bites at the apple. And it's going to have to take multi-sector. It's going to have to take all different types of people. I mean, that's why one of those myths that I uplifted in my presentation was people scratching their heads saying equity doesn't impact me. Equity isn't part of my job. Because the more that people think that way, the more we will continue to deal with inequitable systems and inequitable structures. The earlier that people can start to see their connection to this, I don't want to say it's faster because it's still going to take a ton of time. But, if you think about the legacy of slavery in this country and the history of racism, that's a long chapter of American history, the impacts of which we continue to feel today. We are just I don't even know what the right analogy is. We're like still peeling back all those different layers of the onion. So, I lift up these studies not to say that we're going to do it all tomorrow, but to your point, Kweli, is to get people angry enough so that they can start thinking, what can I do today? I'm a big fan of Ibram Kendi's work. And he tells us, right, like in order to fight racism, we have to figure out what is racist about a facially neutral policy, and then figure out actions to dismantle it. But we have to name it as such first. It's my attempt to try and answer a big question in a short amount of time.
Yeah, no, thank you. That was good. And I want to follow up with a question on this for Terry, which is, one thing many people have learned over the last few years is how important it is to have practical approaches to addressing inequity and issues related to systemic racism. And so when it comes to very specifically, doing the work that we can do to avoid unnecessary institutionalization, I guess my question to you is, what are some very specific things that you think people can be doing that can get us closer to being able to do that in the work that we do on a day-to-day basis?
Yeah, right. Denny, she keeps asking these questions that we really have the answers to, but let me go back to, kind of, envision globally and act locally. And so I'll start, I have to a little string around my finger to get to very specific, but President Biden opened his administration with comments about improving the care economy. All right, the care economy is everything that has to happen in order to make most everybody else go to work, right? And so it's child rearing, it's family support, it's support for older adults at home. It's caregiving by paid caregivers. It's caregiving by informal caregivers who aren't paid, who And for everybody who's done it, what a ton of work, right? So Biden put all that out there, and then he dropped it because he had some other priorities, bless his heart. We have to keep pushing for that vision. The United States is terrible when it comes to both health status in general, and certainly when it comes to this care economy stuff. We just don't support it. So then back locally, how do we do that? We have to be able to articulate this vision that addresses equity, that addresses racism, and that addresses, and that does address poverty. But that means as individuals and as organizations, we have to actually work together. So back to the practicals, really practical stuff. There was a deadline yesterday for the accountable communities for health, state of California, et cetera, putting out all this money. And I'm not sure anybody from Alameda County applied, because what you have to do is work together across healthcare organizations, across delivery system, community-based care, and public health, and think about how can we bring it all together. And similarly, I put in my slides, a month from now, there's a deadline for a local master plan for aging. Well, in order to get those kind of dollars, you have to be able to demonstrate to the funder that you've got a bunch of organizations who are talking together, who are accountable to each other, who are going to hold each other accountable over years. And, hopefully somebody's going to apply for that grant. But if we don't, there are other funders who could bring more money into Alameda County if we could get our act together. So I think it's time for us to hold ourselves more accountable as individual activists, and for our activist organizations to begin to talk to one another and understand the differences, the historical differences, for instance, across different race and ethnic groups. African American, has different inequities than, let's say, the Filipina population, with 20% of the RNs in California are Filipina. Hello, so you have to understand, I think, the impacts of inequity on different populations in order for us to talk respectfully to each other and then work together for a common vision.
Great, thank you.